All right, so we're going to do one more PEDS ID session here, which is going to be fairly short. Just going to take you through some more rare entities that will be on your exam that you need to know about. So these are common zoonoses, and we'll do it in the same format. So a 7-year-old boy develops fever, headache, severe myalgia, and a dark rash on the hands and arms over a 5-day period upon returning from a trip to North Carolina. Physical exam, he's febrile to 39, has meningismus and a petechial rash on his upper extremities. His white count is 3,000, his platelet count is 90,000, and a serum sodium of 129. And this is what the rash looks like, which is a true statement concerning the most likely diagnosis in this child. So serum serologic tests performed early in the course will likely demonstrate evidence of the infection. A blood culture is likely to be positive. Bone marrow exam will be required to reveal the etiology. Supportive therapy without antibiotics is the mainstay of therapy, or doxycycline is the treatment at all ages. Okay, very good. So this is a classic Rocky Mountain spotted fever, certainly clinically and epidemiologically, history of travel to North Carolina, caused by Rickettsia rickettsii. Remember that ticks are the natural hosts, reservoirs, and vectors, and wild animals often serve as reservoirs as well. About a third of cases of Rocky Mountain spotted fever in this country occur in the pediatric age group, and that's why we all need to recognize this infection, which usually occurs in the southeastern part of the U.S. and mainly in the late spring through the fall. These are the symptoms of fever, headaches, myalgia, nausea, vomiting, anorexia. The rash can be maculopapular or petechial and can progress and is one of the few rashes that starts on the extremities and moves inward. Laboratory features are usually classic. Thrombocytopenia, hyponatremia tends to be very common. These kids are almost always leukopenic. They may be anemic, and they may have elevated liver enzymes, elevated bilirubin, and increased BUN. So this shows you the distribution of the tick that spreads Rocky Mountain spotted fever, mainly in the south central United States, and a little bit in the Midwest as well. Yeah, this is just another rash showing you the petechial rash on the extremities. So the differential diagnosis, meningococcemia, atypical measles, which we don't see, Henoch-Schönlein purpura, the enteroviruses, and ehrlichiosis. These are the rashes that can characteristically start on the extremities. Diagnosis is not always easy, so you should presumptively treat these children based on your clinical suspicion. Serologic assays are not going to be sensitive in the first week. There are some fluorescent and peridoxidase-tagged antibody tests that you can do directly from the skin lesions, but these are not widely available. So definitive diagnosis is really difficult, and you should initiate therapy again presumptively upon suspicion. Doxycycline is the drug of choice at any age because it is by far the best antibiotic and maybe the only antibiotic to really treat this infection. And a delay in treatment is definitively associated with increased risk of death. So in July, a 10-year-old girl develops fever, headache, myalgias, and abdominal pain after returning from a fishing trip to Missouri 1 week ago. Her parents noted that she and family members sustained multiple tick bites during the trip. She's febrile to 39, appears ill, and has meningismus. She has no rashes. Again, the white count is low, 2,400. She's anemic, and her platelet count is 100,000, and her ALT is 120. So what's the most likely diagnosis in this patient? Is it tularemia, leptospirosis, cat scratch, ehrlichia, or Lyme disease? So it sounds very similar to the previous case, except she's from Missouri and there's no rash. All right, very good. So this is ehrlichiosis. So this is the classification. There's human monocytic ehrlichiosis, human granulocytic ehrlichiosis, and granulocytic. We now know this is caused by anaplasma, whereas this is caused by Ehrlichia schaffensis, and this is Ehrlichia ewingi. And these are the different ticks that are responsible for being vectors, and this is the part of the country where these are found. These are the reservoirs, the white-tailed deer, and the white-footed mouth. And then this is the area of distribution of Ehrlichia. And you can see here it's similar to Rocky Mountain spotted fever, but is more so found in the central Midwest area. This is the distribution for anaplasma, mainly in the Northeast and the upper Midwest, Minnesota and Wisconsin. And this shows you the different ticks and where each of these is found. So the clinical features are identical to Rocky Mountain spotted fever, except there is usually less rash. So if you hear a story that sounds just like Rocky Mountain spotted fever, but there's no rash, it's going to be ehrlichiosis. They are more likely to be anemic. They generally have more leukopenia, thrombocytopenia, and hyponatremia also is very common. The diagnosis is usually made by serology, and these kids may also have these intraleukocytic inclusions called moruli, which I'll show you, and the treatment also is doxycycline. These are these intracytoplasmic moruli right here. Okay, so question 3 is a previously healthy 7-year-old who's returned from rural Arkansas, where she was visiting relatives, develops high fevers, myalgias, pharyngitis, and swollen glands in her right neck. On physical exam, she has a small papule in her neck with regional tender lymphadenopathy just inferior to the papule. Blood culture grows a small gram-negative coccobacillus. Which of the following is the most common route of transmission of this organism? Is it aerosol inhalation, pet exposure, tick bite, contaminated water, or fecal oral spread? So this is tough because you have to know what the infection is and then the most likely route of spread. Okay. Well, a lot of you went for pet exposure. This is what? This is tularemia. And the most common route of spread of tularemia is actually a tick bite. Okay, so the right answer is C, tick bite. This is tough. So the organism is Francisella tularensis. And again, this is most commonly acquired in the central states, such as Arkansas, Missouri, Tennessee, and Texas. And although direct animal exposure, such as rabbits, hares, are important reservoirs, and certainly somebody who skins rabbits is much more likely to get this, but the most common route of transmission is the tick bite. But I will say that on the exam, they classically give you somebody who is skinning rabbits or somebody who's been eating rabbits, okay? The diagnosis is usually based on exposure to the organisms, again, usually a tick bite with a clinical picture, and serology also can be helpful. And sometimes you do grow this blood from the blood culture. And treatment is with an aminoglycoside, usually either streptomycin or gentamicin. There are different forms of tularemia. The one that they're likely going to give you is the ulceroglandular form. This is the one that this child that I presented had, but there's also glandular forms, oculoglandular. The pneumonic form is quite rare, but is the one that's most likely to be associated with bioterrorism. And finally, oropharyngeal. So the classic symptoms are fever, lymphadenopathy, and pharyngitis. There may be a history of an ulcer or a papule at the site of the tick bite, myalgias, arthralgias. This is frequently confused with cat scratch disease. 12-year-old boy returns from summer camp in New York and is noted to have a left seventh cranial nerve palsy. On exam, he has a rash on his back, which is a large ring with a clear center. Okay, you can see this. There's a clear center here, a halo, and the large ring. Of the following, the most appropriate next step in management is to obtain a biopsy of the perimeter of the skin lesion for Borrelia culture or PCR, obtain serologic studies for Borrelia, treat the patient with doxycycline orally, treat the patient with intravenous ceftriaxone, or treat with prednisone and acyclovir. Okay, so most of you picked up that this is Lyme disease. So Borrelia burgdorferi is the bug, and the classic manifestations, erythema migrans is the classic rash that this child has. They may have other constitutional symptoms such as fever, malaise, headache, arthralgias. Arthritis, which is associated with Lyme, is usually non-symmetric, and it's usually large joints. So it's usually the knee or the ankle. It's usually tender and very swollen, and it's usually one joint. Carditis is relatively rare in children, so they're not likely to ask you or present that to you. But the neurologic findings are quite common, especially the nerve palsies, especially seventh nerve palsy. So seventh nerve palsy, plus a history of exposure, especially in the Northeast, the ticks is going to be Lyme disease until proven otherwise. They may also have an aseptic meningitis. This is the distribution as of 2015, and as you can see, Lyme disease is really concentrated out here and over here. Still pretty rare in this state. We're starting to see some true cases of Lyme, but it's still, most of the cases we see have a good travel history, okay? So the treatment in children 8 years and older, doxycycline is the treatment. Younger than that, it's amoxicillin. With early disease, 14 to 21 days. If they have multiple rings of erythema migrans, we treat for 21 days. The isolated nerve palsy is usually 21 to 28 days, and arthritis is 28 days. We use ceftriaxone for arthritis, for persistent or recurrent cases, as well as carditis and meningitis. 9-year-old child presents with a 2-week history of an enlarged submandibular lymph node. Physical exam, he is afebrile, non-toxic, and has a 4x4 mildly tender submandibular lymph node with a papule on the face medial to the enlarged node. So that's the photo. Here's the papule, and this is the enlarged lymph node. Oops, let's go back. Further history reveals the family recently obtained a kitten with whom the child has had close exposure. A thorough history reveals no history of exposure to TB. You get a CBC diff and a chest x-ray, those are normal. And you place a TB skin test, and it's negative at 48 hours. What's the best course of action? Complete excision of the lymph node, incision and drainage of the lymph node, no active intervention, treatment with oral cephalexin, treatment with intravenous clindamycin. We're split here between C and D. So the diagnosis is cat scratch disease. Okay, so let's talk about cat scratch. So this is the differential diagnosis of subacute and chronic lymphadenopathy. And we've already said tularemia and cat scratch look very similar. So the way you're going to distinguish those on the exam is with epidemiology, history of exposure to kittens versus the area of the country and the risk factor for tularemia. Tuberculosis, you're going to make that diagnosis because there's going to be a close contact who has tuberculosis. Non-TB mycobacteria, we've already talked about that, and that can certainly be confused with the cat scratch. They're usually going to have a mildly positive PPD. So 90% of patients with cat scratch report exposure to cats, and about 3/4 have a history of a scratch or a bite. Bartonella henselae is the definitive organism, and we do have very good serologic tests to detect this. A single positive IgG is usually all that's required to make the diagnosis of cat scratch disease. Pathology, if you were to biopsy the lymph node, would show the classic necrotizing granuloma with microabscesses. So if they describe that to you from a biopsy, you're going to think cat scratch. So clinically, you know, again, these kids usually present with subacute to chronic tender regional lymphadenopathy, most commonly in the axillary lymph nodes or the neck. And the macule or papule, which is the site of inoculation, is going to be found in about 60%. Fever and nonspecific symptoms may or may not be there. Atypical clinical manifestations are not uncommon with cat scratch. This perinods oculoglandular syndrome occurs when the site of inoculation is the conjunctiva, and there may be a small granuloma there with preauricular adenopathy. I'll show you a picture of that. CNS complications also occur mainly in encephalitis and neuroretinitis, and these kids can present with seizures. Sometimes they can be pretty intractable. And then this is also, remember, a common cause of FUO in children, especially when they present with hepatosplenic disease, because they actually get these granulomas and small abscesses in their livers and spleen. The history and physical exam findings are usually characteristic. Lymph node biopsy is not usually required. We have a very difficult time culturing the organism even when we biopsy this. And when we suspect this, we usually do serologies, and those are usually positive. So this is a conjunctival granuloma here, which is the site of inoculation. And this is the same child with preauricular lymphadenopathy and the conjunctival. This is called perinods oculoglandular syndrome, which is commonly associated with cat scratch disease. So cat scratch is usually benign and self-limited. However, it can last for 2 to 4 months. Needle aspiration is only done when it's extremely painful and you want to relieve symptoms. It's usually not done diagnostically. We don't like to incise and drain these when we're confident about the diagnosis. You don't need to remove the node. We will occasionally use antibiotics, but the only antibiotic that's really been shown to work in this situation is azithromycin, which may shorten the duration in acutely or severely ill patients. And we do tend to use antibiotics for atypical disease, such as in immunocompromised children. And in those cases, we would use azithromycin or gentamicin, sometimes Bactrim. Cephalexin does not work against this organism. That's why choice, going back here, choice D is not correct. So in most cases, we don't need to treat these kids. And if we are going to treat them, we would use azithromycin. Okay, and I think this is the last question. This is a tough one. 5 days after being bitten by a pet mouse, a 7-year-old child develops abrupt onset of fever, chills, rash on the extremities, muscle pain, and vomiting. And you appropriately suspect rat bite fever. Okay, this is the bite of the rat. This is a real patient that we actually saw in our clinic. This is the bite, and this is the rash, which could very well be Rocky Mountain spotted fever too. So what's the blood culture most likely going to grow? Pasteurella, group A strep, Streptobacillus eikenella, or Bacteroides fragilis. So the causative agent of rat bite fever. This is a bonus question. It may show up on the primary boards. It's not gonna show up on your recertification exam. All over the place. Okay, most of you got this. So this is Streptobacillus moniliformis, just something to keep in the back of your mind. Rat bite fever is transmitted from rodents, either rats, squirrels, mice, and in the United States, the Streptobacillus moniliformis causes fever, chills, rash, myalgias, very much mimics Rocky Mountain spotted fever. They can have pneumonia, endocarditis, meningitis, and treatment is usually with penicillin or doxycycline. Okay, so we are done. I made up the 10 minutes that I lost beforehand. So Dr. Melton is gonna get us to lunch, and he's gonna do the allergy and immunology board simulation session.